Hello everyone, and thank you for listening to my presentation. My name is Alison Welch, and today I will be presenting my Doctor of Nursing practice project for the Catherine Macaulay School of Nursing at Maryville University. The title of my project is the Morse Fall Scale Tool Effects on Inpatient Fall Occurrences. First and foremost, I would like to introduce and thank the committee members involved in this project, my chairperson, Dr. Joanne Kern, the second reader, Dr. Lisa Struer, and the community member, Tiffany Back, who's a registered nurse and the clinical manager of the acute care inpatient step-down unit where this research was conducted. I will start with the background and significance of this project. The research question for this DNP project was, in acute care step-down patients, what was the effect of implementing the Morse Fall Scale Risk Assessment tool compared to previously utilized routine fall prevention strategies to decrease the fall rates amongst this inpatient population? The purpose of this project was to explore the impact that the use of the standardized fall risk assessment tool, the Morse Fall Scale tool, had on fall occurrences in the inpatient step-down unit. I hope to decrease the rates of inpatient fall occurrences through the use of the Morse Fall Scale tool, as this tool aids in the early identification of those who are at risk of experiencing an inpatient fall. This quality improvement scholarly project aimed to implement the Morse Fall Scale tool to decrease the number of inpatient falls on the step-down unit through statistical data assessment, as well as identifying gaps in current fall prevention processes to make recommendations for compulsory policy change. Secondary aims included improve compliance with the guidelines regarding screening for those at high risk of inpatient falls, increase quality care and patient safety, decrease patient mortality and morbidity, decrease fall-associated hospital costs, and increase knowledge of the Morse Fall Scale tool utilization and subsequent intervention implementation. Next, I will go into describing a review of literature I have completed. A review of the literature included 12 scholarly articles. This review revealed the following 5 themes: the standard fall prevention methods, fall rates, inpatient falls and subsequent injury, Morse fall risk screening tool, and staff knowledge and compliance. Ample evidence confirms that universal fall precautions, inclusive of some techniques such as hospital bed in lowest position, bed wheels locked, use of side rails, are all helpful measures in preventing and reducing inpatient falls. While universal fall precautions were a standard to decrease the occurrence of inpatient falls, universal fall precautions did not address the individualized patient's risk of potential for fall associated with the inpatient's current status of health and acuity of illness related to their acute disease process that affects a multifactorial range of considerations impacting the patient's increased risk of fall potential. One study showed that the multifactorial and individualized interventions concluded from the patient's fall risk factors are more likely to reduce falls than universal fall precautions, correlating with the necessity of a fall risk assessment tool or universal fall precautions, which do not address the patient's specific fall-associated risk factors. Another study identified 10 categories or conditions that expose the inpatient population of the acute care unit to an increased risk of experiencing falls, and some are listed as follows: medications, altered elimination, confusions or disorientations, to list a few. The identification of fall-associated risk factors reinforces the necessity of a fall risk screening assessment tool for effective fall prevention strategies tailored to each patient's identified fall risk-associated factors. Congruently, several studies do show that when compared to the lack of universal fall prevention interventions, the implementation of a standardized fall prevention intervention does decrease the patient's risk of experiencing an inpatient fall. When comparing these studies to those that utilize a standardized fall risk screening assessment tool, this data shows a clinically statistically significant improvement in fall rate reduction when implementing a standardized fall risk assessment tool such as the Morse Fall Scale tool, compared to the universal fall precautions. The use of a set of evidence-based standard fall prevention interventions was a useful starting point in the generalization of fall prevention, fall reduction, and associated policies and protocols. Research found that fall rates or fall occurrences are responsible for up to 84% of adverse events that occur in hospitals, making the average fall rate in the United States about 3 to 5 inpatient falls per 1,000 inpatient days, with approximately 1 million annual inpatient fall occurrences. After reviewing the literature utilized, there was found to be significance of fall occurrences identified in inpatient settings, as inpatient fall occurrences affect patient outcomes, patient safety, patient disposition post-hospital discharge, and hospital reimbursement. For the Centers of Medicare and Medicaid Services, in acute care settings, falls are common yet preventable adverse events that have potential to result in injury that increase patient morbidity, mortality up to 34%, and associated health care costs. Therefore, due to the nature of falls being identified as preventable, CMS no longer authorizes reimbursement to healthcare systems for treating inpatient fall-related injuries, making the use of a standardized fall risk screening assessment tool, such as the Morse Fall Scale tool, a vital aspect of preventing and reducing inpatient fall occurrences. One study showed a decrease in fall rates of more than 50% less inpatient fall occurrences after the implementation of the Morse Fall Scale tool. Another study showed that the utilization of the Morse Fall Scale tool with the implementation of patient-specific recommended fall risk score-based fall prevention interventions decreased inpatient fall occurrences by nearly 80%. Research found that inpatient fall occurrences with subsequent injury is a worldwide issue, naming falls to be the second leading cause of unintentional injury worldwide, resulting in 684,000 individuals dying from falls. Amongst patients aged 65 and older, this population is at highest risk for experiencing an inpatient fall with subsequent injury due to two identified factors of geriatric populations, being their decrease in functional reserve utilized to maintain their orthostatic position, and vulnerabilities or pathologies caused by factors that occur simultaneously. Furthermore, this population of patients are at risk of experiencing both non-fatal and fatal injuries related to inpatient falls. Utilizing the Morse Fall Scale screening tool, despite this geriatric population's pathological, pharmacological, and functional reserves, fall risk scores were identified through a set of factors that were selected and scored if applicable to the patient. These generated scores did help to identify the level of fall risk a patient has in relation to the potential for falls, subsequently reducing inpatient fall occurrences for high-risk patient populations. The Morse Fall Risk Screening Tool is a rapid and easy-to-use methodical screening tool that identifies risk factors for inpatient falls. This tool is not only utilized to predict future falls, but identifies risk factors associated with an increased risk of falls and initiates interventions to address the identified risk factors. A study showed that the majority of nurses, 82.9%, rate the scale as quick and easy to use, and 54% estimated that it took less than 3 minutes to screen and score the patient for fall risk. Literature suggests translation of the Morse Fall Scale risk classifications into practice, exemplifying correlation and predictability between the prevention of the occurrence of falls and implementation of the Morse Fall Scale tool to appropriately predict those at high risk for falls. Evidence focused on implementation and utilization of this Morse Fall Scale tool, suggesting statistical significance in decreased fall rates. Current best evidence focus on implementation and utilization of this Morse Fall Scale tool as well for the decrease in inpatient fall occurrences, therefore recommending practice change in fall prevention processes through the proper use and compliance of adherence to the Morse Fall Scale tool. It was noted that staff knowledge and compliance is an impactful factor when assessing patient for fall risk through the utilization of the Morse Fall Scale screening tool, as patients are considered to be nursing sensitive outcomes because fall incidents have been linked to quality of care delivered by nurses. Historically, nursing practices are geared towards increasing patient safety and promoting patient positive outcomes, making nursing the ideal discipline to re-educate and reinforce the proper utilization of fall prevention tools and techniques through improved practice standards and fall prevention programs. Literature suggests that nursing judgment and consideration of the entire physical assessment and history of a patient helps to determine and tailor a fall prevention strategy through the use of the Morse Fall Scale tool. One study did show that the implementation of evidence-based fall practice prevention strategies exemplified success and outcomes, increasing the nursing staff knowledge and awareness of the Morse Fall Scale tool use, as well as the Morse Fall Scale tool's recommended frequencies of use. Special attention is paid towards the nursing identifying fall prevention techniques for those that are rated high or low risk of falling. Another study did show that Those that were educated on the Morse fall scale tool and in full compliance with the recommended use of the Morse fall scale tool had a 92% success rate in fall prevention and reduction. Current evidence concluded the percent of nurses with general knowledge on fall prevention and identifying those at risk was only 56%. And of those 56%, only 51% of nurses identified their hospitalized patients to have no risk of falling, and only 3, which is 5% of those nurses, said that the patient's risk of falling due to physiological problems could be prevented by providing a safe environment, showing the need to strengthen nursing knowledge about fall prevention in patients through continuously educating and re-educating the staff about the importance of fall prevention, fall risk factors, and proper use of the Morse fall scale tool. These themes do correlate with the vital necessity of the implementation of the Morse fall scale risk assessment tool to prevent and reduce inpatient falls. I will now talk a little bit about the theoretical framework behind this project. A strong way to link current evidence-based practice with nursing theories by finding a model that actually parallels the phenomenon of interest. This DMP project was best represented by Everett Rogers' PDSA cycle, or Plan, Do, Study, Act cycle, which is a 4-step cycle often applied to quality improvement initiatives and is aimed at implementing a change, problem solving, and continuously improving processes, as its cyclic nature allows the theoretical framework to be utilized in a continuous manner for ongoing improvement. The evidence-based cyclic framework is advantageous and applicable to this project because it focuses on a methodology specific to implementing a stepwise quality improvement plan. The PDSA cycle is comprise different stages of tasks implemented in an interactive way with the aim of to improve a process such as the implementation of the Morse fall scale tool for fall prevention and reduction. The intervention used for this DMP project was the implementation of the Morse fall scale risk assessment tool, where the plan stage of this framework applies to the realization of the need for change, as there was an increasingly alarming number of inpatient fall occurrences at this project site, which then prompted the DMP student to develop a quality improvement plan to implement a standardized fall risk assessment screening tool, the Morse fall scale tool, to mitigate this patient safety issue. The plan was formulated to compare the pre- and post-intervention period to assess if the post-intervention period where the Morse fall scale tool was implemented and utilized had any effect on decreasing inpatient fall occurrences. The do step of the cycle involved the actual execution of a proposed plan, being the implementation of the Morse fall scale tool during the post-intervention time period. During this stage, education was provided to the staff to competency each staff member on the impacts of the inpatient fall occurrences, fall prevention strategies, the Morse fall scale tool, as well as proper use and compliance with the Morse fall scale tool. This was applied through necessary Morse fall scale tool education and recommended guidelines, as a DNCP student provided education to the staff in forms of in-services, shift huddles with handouts of the Morse fall scale tool, which helped to familiarize the staff with the Morse fall scale tool components and quality improvement change. This helped set the expectation and reinforce the new behavior change to come. After staff was competent on pertinent Morse fall scale tool information, the Morse fall scale tool was rolled out. During the next stage, the study stage, there was an execution through gathering and analyzing the data and research results of the pre- and post-intervention periods, comparing and assessing the effects of the Morse fall scale tool on fall rates and pertinent details inclusive of the compliance of the Morse fall scale tool frequency as recommended by the creator. This helped to identify gaps for potential areas of improvement. Lastly, the ACT phase of the cycle, the plan of implementing the Morse fall scale tool for the purpose of fall prevention and decrease inpatient fall rates was deemed successful and adopted with consideration of adaptations such as re-educating the staff about the recommended frequencies of the Morse fall scale tool use, as this tool is created to be utilized upon admission every 4 hours with any change in mentation or administration of medications that had the potential to affect the patient's functional abilities or mentation. At this stage, the use of the Morse fall scale tool became the new norm and standard of care when delivering quality care that helped to prevent and decrease inpatient fall occurrences. Everett Rogers' PDSA cycle involves ongoing reassessment through each phase of the cycle, which allows for the consideration of predictions towards a test of change, analysis, and conclusion regarding the best quality improvement interventions to initiate moving forward in each step. Furthermore, the continuation of reassessing and re-educating the staff throughout the quality improvement change was a key factor to the success of hardwiring this change. All phases of the cycle facilitated the learning and guidance of subsequent cycles to follow, and each step of the PDSA theoretical change cycle facilitates focusing towards building vital fundamental knowledge necessary for the enablement of quality improvements. A little bit about the design and methods for this project. The Doctor of Nursing Practice project included an observational retrospective chart review of the selected EMRs that met the inclusion criteria. It was a pre- and post-intervention quantitative exploratory study. The DNP student reviewed results of the facility's monthly fall occurrence reports to determine the impact that the implementation of the Morse fall scale tool had on inpatient fall occurrences. Data collection instruments for the project included the EMRs that met the inclusion criteria, as well as a table created by the DNP student to assess the pre- and post-intervention fall rates. As you can see, the table shown here is an example of the data collection sheet created for the utilization for this project. Now I will explain the sample for this study. Based on the following inclusion and exclusion criteria, and according to the statistical analysis, this project included 154 total subjects. The inclusion criteria, as you can see, is listed here, as well as the exclusion criteria, which each EMR was assessed for and either included in this project or excluded from this project based off of the criteria. I will now go into the data analysis. Descriptive statistics provide a way to summarize data and synthesize findings. Data is then broken down into levels of measurement to guide the selection of the correct statistical test. The data analysis of the Morse fall scale tool utilized was nominal and ratio data, as a fall occurrence did or did not occur, for representing nominal data, whereas the ratio data was a number of fall occurrences in the post-intervention period where the Morse fall scale tool was utilized, and compared to the number of falls in the pre-intervention period in which the Morse fall scale tool had not yet been implemented. The dependent variable was fall occurrences, whereas the independent variable was the Morse fall scale tool. The dependent and independent variables were compared by assessing the effects of the independent variable, the Morse fall scale tool, had upon the dependent variable, the fall occurrences. This quantitative data analysis included a sample size of 154 patient charts. Using the statistical package for social sciences, or the SPSS software, a z-test for the difference between two proportions was conducted, revealing that the statistical significance of the effects of the Morse fall scale tool on decreasing inpatient fall rates by 50% when comparing the pre- and post-intervention data, with a p-value of 0.038. Here I will discuss the results of the project. The mean or average of the pre- and post-intervention was 0.234 in the pre-intervention period and 0.078 in the post-intervention period. Therefore, the average actually decreased by 0.156 points. Overall, there was 50% less inpatient falls after the implementation of the Morse fall scale tool when compared to the pre-intervention period. The standard deviation measures how dispersed the data is compared to the mean. The pre-intervention standardized deviation was 0.078 and the post-intervention standard deviation was 0.34. This showed a significant decrease of variability, as they are relatively distant from the mean, as well as the expected confidence interval of 95%, making this population mean 1.96 times above and below the standard error of the mean. The effect size is the difference between the two groups, which was 0.1558, and the power analysis of 0.85 revealed a statistically strong power. The DNP student used the z-test for the difference between two proportions to compare the data. This test is a special form of a chi-square, comparing the two ratios, the pre- and post-intervention data, to see if they are similar or not. The test revealed a statistical difference between the pre- and post-fall rates, with a p-value less than 0.038. Out of 77 patients, 18 patients experienced a fall in the pre-intervention period, where only 6 of the 77 patients experienced an inpatient fall in the post-intervention period. Therefore, there was a 50% decrease in fall occurrences in the post-intervention period where the Morse fall scale tool was implemented. It was found that family members' presence predominated fall occurrences, and most fall incidents occurred between noon and 4 p.m. This table shows a number of total EMRs utilized for the pre and post interventional period, with pertinent fall occurrence data showing a significant decrease in fall occurrences in the post intervention period. This chart depicts the fall occurrence with injury, fall prevention, and increased length of stay in the pre and post intervention periods of the Morse Fall Scale Tool implementation. As you can see again, all aspects of the post intervention data were decreased with the use of the Morse Fall Scale Tool implementation. Identify the following limitations of the study that may have impacted the results and are: upon the initial implementation of the Morse Fall scale, the staff exhibited varying compliance with the tool's defined frequencies of use. So lack of staff compliance with the Morse Fall scale tool frequency was found to be noteworthy during the night shift, as the researcher and leadership were not present at this time. It was found that the majority of night shift staff displayed noncompliance with the Morse Fall scale tool frequencies, as they were travelers employed by staffing agencies to accommodate the influx of COVID-19 patients. These limitations were identified timely, and re-education of the Morse Fall scale use frequency was provided, having a little impact on fall occurrences, especially considering that the majority of fall occurrences were identified between noon and 4 p.m. Other limitations included inconsistencies in quality of data documented by the nursing staff, as some of the Morse Fall scale tool recommended fall prevention interventions were not documented as implemented, though the interventions may have been physically employed. These limitations may have impacted the DMP project study and altered results, as the information may have not been fully encompassing, altering its reliability. For instance, preventable fall incidents could have occurred post-intervention because no interventions were applied to the specific patient. After further and thorough investigation of the post-intervention fall incidents, it was found that the patients who suffered an inpatient fall in the step-down unit had appropriate fall prevention interventions. Also, more data would have to be done to lead a thorough analysis. While the sample size was considered to be adequate, a large sample size could be provided for more data for a better idea and general consensus of the impact of the Morse Fall scale tool on inpatient fall rates. The main question here is the research question that in acute care step-down patients, what was the effect of implementing the Morse Fall scale risk assessment tool compared to previously utilized routine fall prevention strategies to decrease fall rates? Although after thorough data collection and rigorous statistical analysis, I determined that yes, the hypothesis of this implementation of the Morse Fall scale tool would help to prevent and decrease inpatient fall occurrences. The findings of the CMP project prove that the use of the standardized fall risk assessment screening tool, such as the Morse Fall scale tool, can prevent and decrease inpatient fall occurrences. The Morse Fall scale tool can and should be used to prevent and reduce interventions, as literature correlates the study findings that the use of the standardized fall risk assessment screening tool, such as the Morse Fall scale tool, does indeed prevent and reduce inpatient falls. Furthermore, assessing and identifying patient-specific fall risk factors can prevent and reduce the likelihood of inpatient fall occurrences when used in combination with the recommended fall risk score specific fall prevention interventions. This is shown to be a direct link between assessing the individualized patient's fall risks, implementing the recommended fall risk score and prevention interventions, and a decrease between the amount of inpatient falls. Furthermore, fall prevention and reduction is shown to decrease the length of stay, loss of hospital reimbursement, injury related to fall, and resulting in declination of functional abilities, patient morbidity, and patient mortality, concluding that the Morse Fall scale tool is a valid approach to the delivery of safe and quality care through the prevention and reduction of inpatient fall occurrences. The result of the CMP project confirmed that the Morse Fall scale tool positively impacts inpatient fall prevention and reduction by reducing inpatient fall occurrences by 50%. The study also adds to the growing body of evidence that there is a connection between the implementation of standardized fall risk assessment screening tools, such as the Morse Fall scale tool, and the reduction of fall occurrences. The Morse Fall scale tool can and should be used as an intervention to address inpatient fall occurrences. Using this fall risk assessment screening tool to identify patients that are at an increased risk of experiencing an inpatient fall can improve patient outcomes and patient safety. Healthcare institutions should consider the use of the standardized fall risk assessment tool that are backed by evidence as valuable interventions. The Morse Fall scale tool could improve patient safety and patient outcomes by decreasing the length of stay, loss of hospital reimbursement, declination in patients' functional abilities, patient mortality, and patient morbidity. The Morse Fall Scale Risk Assessment Tool standardizes care so that all patients can receive the fall risk assessment to decrease and prevent inpatient fall occurrences, which is substantiated in the research. This project integrates essential future research on employing fall prevention interventions as an efficacious strategy for cultivating culture of safety through the Morse Fall Scale tool utilization. For implications of future research moving forward, it's crucial to continue evaluating the effectiveness of the Morse Fall Scale tool compliance in reducing inpatient falls, as recommended by Rogers' PDSA cycle, and to explore other potential factors that may contribute to fall prevention efforts by addressing these complexities. Healthcare systems can further improve patient safety and outcomes in the future. On a systemic level, this project implies that the use of a standardized fall risk assessment screening tool, such as the Morse Fall Scale tool, can be effective and beneficial to all that use it. Some conclusions I determined from this project are that there is statistically significant evidence to support the use of the Morse Fall Scale tool to prevent and reduce inpatient falls. Through the implementation of the Morse Fall Scale tool, there was statistically significant evidence that correlated with a reduction in inpatient falls, which positively impacts patient safety and patient outcomes by reducing fall-related injuries such as bone fractures, reducing the declination in functional abilities, and reducing patient mortality and morbidity. Based on these findings, there should be more funding towards the quality improvements of fall prevention education and research. Institutions that care for acute care inpatient populations should consider implementing the Morse Fall Scale tool as part of the practice or interventions for fall prevention reduction strategies. These findings will impact practices on a larger scale because they offer an opportunity of quality improvement fall prevention strategies for inpatient areas that experience high volume of patient fall occurrences. Taking a root cause approach to identify gaps in fall reduction and prevention strategies provides notable fall reduction and may prevent injuries as a result of inpatient fall occurrences, as well as improvements of healthcare outcomes overall. This DMP project has helped me tremendously in my feat to better understand quality improvement measures through use of standardized fall risk assessment screening tools such as the Morse Fall Scale tool as they relate to inpatient fall prevention and reduction. My goal as a future doctor of nursing practice is to improve healthcare systems at a system level through the use of quality improvement strategies. This program has taught me how to synthesize, analyze, and implement evidence-based change. To conclude, it is clear that we see that the use of a standardized fall risk assessment screening tool, such as the Morse Fall Scale tool, can help prevent and reduce inpatient fall occurrences and improve patient safety and patient outcomes overall. I'd like to give you some time to ask any questions, and please let me know if there are any comments or concerns. Lastly, please let me know if you want to email me with any of these concerns or questions regarding the project information or findings, as you can reach me at awelch4@live.maryville.edu. This is a list of my references that I've included in this presentation, and thank you again for coming to my presentation and listening to all of this impactful data. Again, I would like to thank all of the committee members who have helped me throughout this DMP scholarly project, as they have helped to make this project come to fruition.